on early infection here, because it's a little different than chronic infection. Disclosures, nothing related to this talk. So we know that infection is one of the most feared complications. Diagnosis can oftentimes be very difficult, and the difficulty is magnified in the early postoperative period because people have normal postoperative pain, they have edema, they have erythema, and the appearance is unreliable because of the inflammatory change. So which one of those knees is infected, or are any of them infected? It's difficult to tell. So diagnosis of chronic infection, we'll just touch on that. In 2013, Musculoskeletal Infection Society made some criteria, major criteria and minor criteria. You can see those there. You need one major, you need 4 of the criteria to have definite infection. You can have less than 4 of the minor criteria and still have infection. And the SED rate and CRP are excellent screening tools, and many authors have shown that the synovial fluid, white blood cell count, and differential have been an accurate way to help diagnose infection. There's varying numbers for the cutoff in the white blood cells. I like to use 3,000 and above. But the diagnosis of acute infection is more difficult because of this inflammatory state that happens postoperatively. So the interpretation of your inflammatory markers and the synovial fluid cell counts, it's not as clear-cut as in the chronic case. And if you use the conventional numbers for chronic, we would oftentimes overdiagnose this infection in the acute state and lead to unnecessary operations. So it's quite different. So there have been a few good studies, and a lot of this work has come from Rush, Craig Della Valle's work, and Jay Parvizzi's work at Jefferson. And they looked at almost 12,000 primary knees, and they looked at all the knees that they aspirated within 6 weeks after surgery, about 146. The mean time of aspiration was 16 days. Now, on this table, just concentrate on the p-values, and you can see that between the infected and not infected, there's not much difference for the SED rate, but for the CRP, synovial fluid, and differential, these were significant. And if you look at these are called receiver operating characteristic curves, and they're plotting sensitivity over 1 minus the specificity, but really what you look for is the area under the curve. And if it's probably less than 70%, it's not really a great test. So area under the curve for a SED rate is 51%, not so good. C-reactive protein, if you use a threshold of 95 milligrams per liter, it's reasonable, 73%. The differential is better if you use 90% basically for your polys, 82%. But the best result is a synovial fluid white blood cell count. And it's kind of bimodal. A good rule out is less than 10,700. A rule in is about 28,000. Area under the curve, 97%. If you correct for, we call an adjusted white blood cell count, that means you take into account how much blood is in the sample, because more blood will give you more white blood cells. If you account for that, about 10,500 is a good number. You get area under the curve of 97%, so that's a good number, a good test. And just a little bit of education when we look at these tables, because it's always confusing. But sensitivity is the ability of a test to correctly identify those with the disease or a true positive. So high sensitivity means very few false negatives, while specificity is the ability of a test to correctly identify those without the disease or a true negative. So high specificity means very few false positives. So if you look at these results, again, concentrate on the bold numbers there. Synovial fluid white blood count shows a specificity of 100% and a positive predictive value of 100% with 27,000 white cells, and a 99% negative predictive value if you're less than 10,000. The adjusted white blood cell count is also quite good, 94% sensitivity and specificity, and again, a 99% negative predictive value, so that's a good test to rule out. Results on hips are similar. They're just smaller numbers. 2,500 hips. Anybody who was reoperated within 6 weeks was evaluated, and they were reoperated for multiple reasons. But it turns out there were 9 infected cases and 23 aseptic. And again, if you look at that table, SED rate, it has an insignificant p-value. The others have a significant p-value. And basically, if you look at C-reactive protein, an optimal cutoff is about 100. Synovial fluid white blood cell count, To round the numbers up, an optimal cutoff is about 10,000. And the differential, again, works out to be about 90%. So all the infected hips had white blood cell count greater than 10,000, greater than 90% on the differential. Thorsten talked about this a lot yesterday, so we'll go through it quickly, but the leukocyte esterase strips is really J. Parvizzi's idea, and it's used to diagnose urinary tract infection, other infections rapidly. And out of this study where they aspirated a number of hips and knees, the bottom line is it's a good test. We saw this yesterday. Thorsten talks about it. A lot of these are unreadable if you use the strip because of blood contamination. You can get around that if you centrifuge your sample, and then you can test the serum still. But the bottom line is it's a good rule-out test. Look at the negative predictive value, and it's in the high 90%. So it's quick and a good test. It fills a void in the diagnosis of prosthetic joint infection, and it's very inexpensive, and you can do it in any practice setting. Again, some of these are unreadable. You get around that if you have a centrifuge available. What about alpha defensin? We talked about that yesterday as well. It's a natural antimicrobial peptide. It's released by the white cells to kill the pathogens, so it's increased in concentration in synovial fluid if there's an infection. There's two good studies. Carl Derminigan has been involved in both of those, J. Parvizzi in the JBJS article. In both of these, they used the Musculoskeletal Infection Society criteria as the gold standard to diagnose infection. But in the article in Core, they had 100% sensitivity and 100% specificity if the alpha defensin was positive. In the JBJS article, again, 97% sensitivity, 96% sensitivity, but if the C-reactive protein is greater than 3, it's 100% on the specificity. So it's an excellent adjunctive test. It's probably the best biomarker. It's probably, I think, most useful in chronic indolent infections where you continue to have culture negative results, but you think they're infected. But it's also helpful in the acute postoperative setting because the results don't correlate with the number of white cells, and the results are not affected if antibiotics have already been given. And it should not be elevated if you have an inflammatory condition, i.e. the postoperative state. It needs to be activated by infection. Having said that, there is a small false positive rate if your synovial fluid is less than 3. There's some reports of false positives in metal-on-metal hips that have adverse reaction to metal debris. And I've had one personal experience in a patient that had a gout, and we had a false positive. It's a quick turnaround for us. We still have to send it into the lab. I noticed that Thorsten has a point-of-service test already, but we don't have that. But we get a quick turnaround, 1 or 2 days. The cost is reasonable, about $100 US. The point-of-service test, you can get immediate results. I don't know if it costs Thorsten less than that. I think the key there is what he demonstrated yesterday is you have to do that test properly or you will get inaccurate results, so you have to be careful. We send ours all to the lab. I think they do a good job. Conclusions, acute postoperative infections can be difficult to diagnose. You can't rely on the appearance of the wound because of the concomitant inflammatory response. Most helpful is the synovial white blood cell count. The white blood cell differential and CRP are also good tests. SED rate is a poor test in the postoperative period. Leukocyte esterase, good, negative predictive value. So if it's negative, you probably don't have an infection. And then Synovia Sure, if it's done correctly, has a very good positive predictive value and negative predictive value. The best test is the synovial fluid white blood cell count. If it's less than 10,000, probably not infected. Differential, again, 90%. CRP is helpful if you're on the fence with a threshold of about 100. So those numbers are easy to remember. 10,000 white blood cells, around 100 on the CRP, 90% on your differential, most likely infected if you're above that. Thank you.